Welcome to today's online learning event, Why Do Healthcare Executives Fail? Sponsored by Murphy Leadership, a company that facilitates running toward the roar while turning risk into opportunity. Hello, I'm Niles Ken, President and COO of Murphy Leadership. I will be your moderator today. Before introducing today's speaker, let me review a few operational details. Please note that there is a question tab in your control panel on your screen. Please send your questions throughout the presentation. We will respond to these questions via email that will be distributed to everyone. Once the webinar has ended, a window will appear for you to open a survey. We would appreciate your feedback when completing the survey. Audio for the webcast is streamed over the internet and is available throughout your speakers on your PC. If you are in an open office, we recommend you use headphones. The link for today's session will be emailed to you within 48 hours of this broadcast. Please check your junk or spam folders if you do not receive the email with the link to the on-demand session of this session. If for some reason you do not receive the link, you can always contact Murphy Leadership. Also, please feel free to share this archived video with your coworkers and friends. Now let me introduce to you today's speaker and presenter. Dr. Emmett Murphy is the author of 14 books, major ones including the New York Times bestseller list, on the New York Times bestseller list, Leadership IQ. He is also CEO of Murphy Leadership, a training and consulting company specializing in professional development that focuses on increased performance and innovation in the workplace based upon research. He has extensive experience working with staff from the C-level to the rank and file in such organizations as Walmart, IBM, and other brand name companies. He has also worked extensively in healthcare, serving such organizations as the Harvard Medical School and Brigham Hospitals, the Voluntary Hospital Association of America, and others. His current research and consulting practice focuses on increased courage and innovation in the front lines and leadership. He holds a PhD in organizational psychology. With that, let me introduce to you Dr. Emmett Murphy to begin today's presentation. Emmett?
Thank you, Niles, and welcome everybody. We're out ready to embark on a wonderful journey, and that's asking the very basic question that all of us think about at some point, and that is, why do we fail? All of you are healthcare executives, and the question is, when it happens, when the worst happens, why does it happen? I think the answer is very simple and straightforward. We do not run toward the roar, or, as they say in the young, I didn't see it coming, and that's the lion who thought I was lunch. The real issue for healthcare executives, and for any executive, and especially I would say in today's society, is the risk of not understanding what risks are emerging, how they are likely to affect us, how fast they are moving, how quickly they can intrude, and basically not understanding the complex array of risk factors facing us. Of course, we can see this in our private culture as well, and in our public culture. Both today are fraught with risk, and we see the problems that occur as a result. Let's take a look at this in terms of the objectives that we want to specifically address in learning about it. Our objectives today are to try and understand how to diagnose emerging problems and opportunities in the clinical and general operations of healthcare. Mind you, this is the most complicated human organizational setting on the earth. I guess that one could say that we don't know about all the levels of microorganisms and their cultural structures, but we could say it's the most complicated living structure on the face of the planet. Basically, what we have in human society is this interplay of roles, of parts, and in following systems theory, the higher the level of differentiation of parts, supposedly, the better the risk for survival, but also the risk for death when those parts are not organized, coordinated, and focused to one purpose. We live in the most complicated organization setting there is. And the difficulty is increasingly fraught with risk because of the complexity we add to the system all the time. So we'll try and understand how to diagnose those problems. We want to discuss the realities of creating a patient-first focus throughout the organization, why it's so important to teach the operational realities of patient-first focus more clearly and embed them in individual role concepts and individual personal understandings of responsibility. We need to engage the entire organization in an evidence-based process. We can't talk about evidence-based cultures without including people in a way that makes it clear what that means. And we have to increasingly delegate responsibilities all the way to the front lines. Presently what we have is a problem, a very serious one, with reverse delegation. And I think that's largely the result of our not understanding how to get the responsibilities out of the executive suite and more properly distributed. And that is what we have to make sure we focus on today as well. We also need to compare our competitive readiness to others. We need to understand what the best practice standards are for managing risk and be more clear about where we are. It's the old frog boiling in the water syndrome. You know, the water heats up, and the next thing you know, we're boiling, and we didn't recognize it. It's very easy to think that risk is at 1 and 2, when in fact it's at 5, 6, and 7. We need to apply a new technique called cluster analytics, because when we look at discrete variables one by one, or in our typical notions of how they come together, we typically miss the risk signals. To do this in the context of mastering a new diagnostic tool, which I want to share with you. When we look at risk in a very specific, concrete terms, we can better understand what it is we're going to be talking about today. So I'd like to ask all of you to take an assessment here. Ask yourself on a 1 to 7 scale, with 1 meaning things are really okay, and 1 meaning things are not okay, and 7 meaning things are just fine. Is the patient first priority in the organization? 1 would mean no, the patient isn't, or you might even answer it with who. At 7, it means the patient is our first priority, is the center of our existence, and 3, 4, and 5 are in between. Is patient the top work priority? Now this is really key. Does the housekeeper understand that's her priority or his? Does plant management? Does the RN? Do we get into the game of who washes hands and not talk to each other for fear of hurting feelings about those kinds of problems? Is patient safety the top work priority? Our top performers retain. The real key here is understanding that without the top performers, what happens is we get a regression to the mean. When the top performers leave our organizations, our standards of performance de facto drops, and it becomes lower. And thus we move from a level 100 performance to a level 90 performance, and the mid-range thus drops from like a 50 to a 45. Our managers able to spend 60% or more of their time in the front lines of work. You know, we can talk all around about appropriate styles and behaviors. If you don't show up, you're of no use. And frankly, in healthcare today, one of the single greatest operational crises we have is that our managers are not showing up in the front lines. Oh, they're rounding because so many people will say, let's round, let's walk around. That isn't being present. Present is engaging in problem solving, is being there. Are the right people doing the right jobs? Here's the ultimate test of things. Are the right people in the right place at the right time, doing the right work for the right reason, at the right cost? We all know we need our physicians when we need them, our nurses when we need them, etc. And if they're not doing the right work, I'll give you one statistic that's troubling. It still remains the case that over 40% of our time on the floors in healthcare is not spent on nursing. Just think about that one. It's spent on other tasks and other things that have become role acquired. Why? That's a real question we have to ask. The first element of design, redesign in the workplace, is to get people doing what they were hired to do in the first place. Is the organization overall more patient-focused today than 3 years ago? Where is our trend line going? And so here we have 6 questions. Now, I can't see you all out there, but typically when we do this, we usually have a couple of folks up to 6 or 7, a small percentage, maybe 3 or 4%. It follows a curve that's somewhat skewed to the left. Our average score typically is 3 to 4 for these 6 items. In the complete assessment, depending on which version we use in an organization, the 60 to 70 items that really nail operational effectiveness, that score nationwide is 3.27. Certainly not something to write home about. When we do this kind of thing, we ask these questions, what does it mean? Well, first of all, the questions themselves, it's important to know that what we have to do when we're assessing things is we often say measure responsibility, not self-interest. We do sometimes, not sometimes, I'd say 80% of the time, employee surveys are filled with narcissism and skewed negatively. So, you ask somebody, have you been, when was the last time you beat your spouse? The answer is implicit in the question. Well, how many times, how effectively does your boss communicate? Well, bosses don't communicate, so we always have low scores. And back serving the organization more than focusing it. We're very concerned with this kind of problem of what we call the fraudulent factor in assessments, and in another webinar we'll be dealing with that, where we talk about the dirty secrets. You can reliably and predictably measure fraudulent items and reliably and predictably skew the results in ways that make the results make them distorted. And that is what happens with so many of our assessments. We're not assessing what's vitally important, and we're not asking questions in a way that invite a straight down the middle, neither yay say nor nay say tendency. Those are techniques that are very important as we go forward in the discussion of assessing. But we say measure responsibility, not self-interest, because it is the duty to, it is the key mission, engages us and defines our organization. That is what we must focus at. We have no reason to be in healthcare without the patient. We all collect a check, or as volunteers derive great personal satisfaction because of a person called the patient. Without that person, without that focus, there's no reason to be there. I'm not sure that's understood. We often talk about everything's equal in healthcare. That is simply not the case. The patient is far more equal. Here are some of the things that when you do these types of assessments and when you do it properly, you're able to spot before they emerge. It's like getting a good lead on prostate or breast cancer through diagnostic, preventive, and prophylactic diagnostics. Most importantly, we pick up signs of instability, and the thing that usually drives instability is the sense of complexity, of being overwhelmed. Patient safety is easily predicted when we look at key variables such as role focus. Role focus will predict patient safety almost more clearly than anything else. Our profitability is a function of safety in today's environment. For every CFO, know that, and I'm sure you do know it, that through our DRG development over the past 20, 25 years and our coding, we have made money, the result, profitability, the result of appropriate diagnoses and treatments. And therefore, you can't effectively profitably run an organization without it being highly safe for patients. Coordination and disconnections are the bane of existence in healthcare, and often we don't see what's happening until it's really at a tremendous earthquake of leadership, the effectiveness of leadership, the guidance system in our organizations. We aren't 747s or 787 Dreamliners. We can't just have computer cybernetic systems controlling the aircraft. We need human beings. And we will for quite some time in healthcare. Thank goodness. The question is the presence of leadership. spotting that tendency and that trend. We often see situational pathology. The more intensely complex an organization, the more you're going to see de facto sociopathology. And you're going to see problems that, if you look at them from a purely clinical perspective, you will say, I recognize that behavior. Healthcare is a wonderful Warren's nest of situational pathology, and most especially when instability hits. Retention of talented people is the essential element in positive change and adaptation. Do we know what's going on? Can we predict it before we see suddenly this hemorrhaging of talent? A culture of blaming versus a culture of ownership. I own the responsibility. Blaming is a function of self-interest, ownership of responsibility. These are some of the kinds of things we can observe and predict, and they have immediate and startling consequences on the patient and all of us. But are we diagnosing these kinds of things? Our experience indicates, in our recent research between 2007 and 2010, indicates that the best leaders are diagnostic leaders. They are driven by this need to know ahead of the curve the degree to which pain points in the organization are alive and throbbing. How do we get at this issue? First thing is to understand the big problem. That is, we live in this hugely complex place. Hospitals and whatever variation on the healthcare theme, and the intensity that accelerates and intensifies the complexity. We also know that to deal with it, to produce the clarity we need, we must have credible information. Otherwise, we increase the complexity through confusion. And lack of credibility undermines everything else that could possibly go right. The person who's most in danger on a specific level, and the person we are ready to shoot at a moment's notice, is the CEO, followed by members of the C-level. That's one reason we're having trouble, frankly, getting really top-flight people to take chances to assume those responsibilities. The job's in the game. The average CEO's job is 600% more complicated than the average CEO in business. The numbers of departments, the various people who can demand responsibility. When you do a role analysis, the CEO's job in healthcare is not a desirable job if you want to have a long life expectancy. The same thing with the nurse managers. The most complicated frontline management job in the world is actually the nurse manager's job in the American Community Hospital. Why is risk so critical? Why do we need to understand this and produce the evidence that defines the risk, makes it clear to everyone? Well, let's take a lesson from the Serengeti. This is it is a wonderful story. When lions hunt on the Serengeti in Africa, it typically is the case that the oldest and the most toothless lion go ahead of a herd of game, antelope or whatever, and upon some signal from the rest of the pride that has now positioned itself at the other end of the herd, the old fellow stands up and roars as loud as he can. That's probably the major skill left for him at that point, simply roaring and complaining. As an older person, I'm starting to identify with this role. So he roars, and the antelope hear the roar, look at it quickly, and turn and run like hell in the other direction, and they actually run into the jaws and paws of the waiting pride and are consumed, literally. Had they run directly at the roar, it would have been much safer. But they didn't get it. And because they couldn't communicate the evidence, they haven't passed the information along, the evidence along, analyzed it, diagnosed it, they become lunch. Well, the same thing happens to us, and the same thing happens. Natives and warriors on the Serengeti have learned, because the information has been passed on over time, that the safest place to go is to head right at the lion, look the roar right in the eye, and say, I know you're more bluster than bite. It's the same thing for us. And we have developed a habit of CYA, and we all know what that means, cover your appurtenances, and other things that procedurally give us places in which to duck. And therefore, often before we ask ourselves, what's the risk, we ask ourselves, what protections do we have from accusation and from accountability, and most importantly, from responsibility? How can we avoid the gotcha? When instead, we'd be much better off asking ourselves, how do we identify the risk? That's what this program is all about. We're one of those firms over the years that has spent a lot of time in this field, looking at issues of risk, working with JCHO, HFMA, which gave us an accolade, the best research internationally, domestically in 1995. You'll see some of that in here. We ended up being adopted, acquired by VHA and so forth, and the database is, we say 1,000 plus healthcare organizations. Is more like systems. If you broke it all down, as all many of you know, into the sub-organizations within, corporations within the system, there are a lot. This is a big industry. So anyhow, we've been around a bit, and I mention that because our credibility has to be out on the table. All of us have to be prepared, as we say in our firm, to go to court to make sure we can teach and explain what's going on. During this past 3 or 4 years, we have launched a major study with friends at MIT, at the State University of New York, at Alliant University, to understand complexity and how it impacts businesses and healthcare organizations. In the case of healthcare, we really want healthcare people to also know their relationship to business people. So we include both. When it all came down, one of the most intriguing aspects of this study, starting with 20,000 leaders, breaking down to 1,000 or so organizations where we had more detail, 982 organizations involved, 1,000 leader sample. When we really got in here, we realized that everybody's going to ask the question about money. And if our research was going to hold up, we needed to take the information and the quality information, compare it, and see whether the behaviors of leaders effectively predicted both. One without the other wouldn't work, and it had to be looked at over time. It ends up that profitable organizations, first of all, are clearly differentiated from unprofitable organizations, and in this very difficult society with economy with very savvy consumers, those organizations that are most profitable are those where work is most clearly defined and delegated, where quality standards are the highest priority, where patient safety instruction is consistent. You can see on the other end of the curve, at the end of the regression line, where patient safety is declared the high priority, where top performers are recognized, and where person work priorities are very clear. What you're seeing is a situation in which leaders have focused on the work of the organization. I brought a group of CEOs to meet with Jack Welch back when he was CEO of General Electric. We were working with them on the development of a technique that became known as work imaging, and which we use with about 500,000 healthcare workers to create the world's largest healthcare worker activity database, to enable the CEOs from healthcare to compare their understanding of their roles. Welch asked them, how do you spend your time? And the CEOs went through and so forth and so on, and it became evident that 70–80% of their time was spent on matters that were pretty much external to the organization. Welch said very candidly that, well, the guy's incapable, not speaking candidly, you wouldn't be hired at GE. We wouldn't have you here. Our CEOs must spend 80% of their time on the issues of quality and profitability. We can delegate everything else, but we cannot delegate quality and profitability. Our CEOs must be the most knowledgeable about our businesses. We can hire people to go out and do lunch, to sell, to do a whole bunch of other things. We cannot hire, the talent, the real talent that understands the business, understands our customers' needs, must be the CEOs of our organizations. That has been a driving perception, very, very simply articulated, no nonsense. And I think what we see in the actual research that comes out is those leaders who are most effective know their business inside and out, have communicated what is happening, and we asked ourselves, what did they do that made this reality occur? And the answer is, they assessed risk. They ran toward the roar. They looked risk in the eye and were always ahead of the curve in identifying risk. The singular attribute of these leaders, when you really get inside their behavior, is their immense commitment to risk assessment as the top priority in their personal conduct. And I think you know that when you look at CEOs. It's hard to have conversation with an effective leader without them probing what you know about what's happening right now. Every conversation is a source of information. Everything is leading to their assessment of what's going on. Many of my friends are docs and my personal physicians. But when the conversation goes a little bit long, they can't help themselves but do a de facto diagnosis of my conditions, of which I have. And if I run into colleagues who are pulmonary people because I have asthma or cardiac stuff, I mean, my goodness, there we go. You know, and I have, as you probably would expect, some very close friends who are psychiatrists to whom I refer a great deal, and they can't help themselves. They are doing diagnoses all the time, and it's both funny and very impressive. Anyhow, you need to run toward the roar to be the effective leader in our time. We're seeing the emergence, clear emergence, that those who are smarter in the real sense of understanding risk are the most effective leaders. They see it, they can deal with it before it gets out of control. And they do this by measuring something we call responsibility. We're all familiar with accountability. It's imposed from without. And typically, especially in our culture, resent extrinsic imposed control. We have to get ready because the JCHO is coming. Medicare is going to conduct an audit. Your boss wants to know what the hell you're doing and why. Well, this is not an effective way of actually getting good performance. You'll get accountable performance, but not truly committed performance, and even the accountability will break down. Responsibility will not. You have to look past this. So these CEOs measure the commitment to their customers, healthcare, to their patients, as never before. They are not looking for just anything. They're looking for indicators that say how effective the business is going to be. And to transform the risk that's identified, they really do take 4 steps. They take the assessment, they diagnose the implications, they ask what it is and who has to but owns the responsibility to see that it's done, and then they act. If this sounds like the nursing process or the clinical process, you're right. I often say to nurses, don't accept this business that you don't know how to manage. You have to separate nursing your patients from nursing your subordinates. That you do have to do. But you're steeped in the clinical scientific process, and that is today the preparation necessary to lead. So we say in our little system of running toward the roar, you have to hear the roar, face it, own it, and then take action. Actually get on the horse and go. Let's take a quick look at the lessons that this kind of experience, this orientation, gives us, and what the research said. Well, we know that like risk is a reality, it's ever present. And the difference between those who are overwhelmed by risk and those who have capacity to see in the risk the opportunity to initiate change. We're wired on the positive side. We now have very clear evidence. Evolutionary science is documenting that the capacity to frame things in a positive context has been essential to our evolution. Seeing risk as an opportunity to grow and change and as a challenge is key to it, but you've got to see it before you're overwhelmed. The higher the level of leadership, the more the responsibility is for assessment, for really spotting that risk. And we often say whoever asks the questions is really the leader. Whoever has the evidence sets the agenda. I guess we want to say, think about it. I'm not the leader right now. I may be talking and so forth and so on, but you're the ones in the position to ask the questions. You're the ones in the position to channel this discussion. You know, I'm carried away here, and it may be a while before you can get me to pay attention to it, given the medium we're involved in. But in real life, those who are asking the questions are the ones gathering the information, becoming more informationally powerful, and those are people who lead and should lead. In many organizations, what you find, the people giving the speeches that have the titles, but the people with the information and asking the questions are the ones who really control the show. One of the greatest mistakes CEOs make and the C-level makes is not to ask questions and really get down to brass tacks. Executives run toward the war to see it coming, to engage those who understand the risk most in assessing it, to share the information. As I said, most of our executives teams today in healthcare are just overwhelmed and tired. And the reason is they're not able to get rid of that information and rid of the responsibility and get it down, largely because they can't explain the problem to others. I think that's the reason for that is the inadequacy of diagnostic tools. Certainly when a pulmonologist shows a person with lung disorder a spot on the lung and explains what that film, what the spot on the film means, or on the screen these days, it gets the attention of the patient. We're not putting our senior leaders in the physician role. We're not giving them the diagnostic tools to explain to the patient, their employees, what is happening. That has to change. So the fourth lesson in this whole thing is also when you diagnose, when you assess, make sure everybody who's affected by it sees it. Such great physicians with really ill patients. And during the course of treatment, they'll pull out the films or the bloods and, with the patient's permission, share them or share the results with the family so everyone involved understands what's going on and what the disease process means. We can't do that if we don't have the proper diagnostic tool, and we need, therefore, a new assessment. We have developed what we call patient-centered operational assessment that makes it possible to run to the law. We're going to talk quickly about how to use it, how to make the assessment, how to conduct a patient-centered operational scan, how to interpret it, how to move towards ownership. One of the most fascinating things is that when we assess and we're involved in the assessment, we own it. If we're not involved in the assessment, we tend not to give a darn. That's a innate pluralistic society. And if you want your employees to understand, to buy in, to accept the delegation of responsibility, you've got to allow them, not even allow them, require them to become involved in assessing operations. And when you do, the magic of delegation occurs. And then people are able to take the action they need to make change, to improve things. Okay, let's get going on this whole thing. Because I know Niles will be interrupting me soon and saying, get going. Here's what we learned. Over 2 million subjects in the research. There are more licensing arrangements and so forth. But what we know is there are 4 elements in every organization that come together to define our lives. Our expectations, human or vision. And in each organization there is a single powerful criterion that defines the obligation and the responsibility set. In our case, it's patient safety. We also need to have sense of expectations for our individual roles and what our work is. Intriguingly, our expectations, other than what you might call the vision statement, aren't real fancy. The expectations are defined by the safety issue, what's required for it. Over 80% of seminal events in healthcare are driven by common sense problems and a lack of managerial oversight. And our work focus is at the heart of virtually all the safety issues. Our jobs, we've made them too complex, they become too complex. We need to know and articulate our expectations and measure them. We need to know they're connected. Since healthcare is the most complicated array of departments, disciplines, and so forth, we need to know how it's held together and evaluate how well it's held together. Do we share a sense of community in how we behave? Do we practice teamwork? I love that word because it's so poorly understood. Teamwork isn't doing the same thing as others are doing. It is doing what is our responsibility, confident in the capacity of our colleagues to do theirs. Teamwork is information sharing. It's respectful. It has very concrete behaviors. Guidance. Without guidance, we fail. Healthcare workers, when asked what is the single one thing in the operational side of their work or their environment that they wish were improved, it is having managers present. Well, I've got to repeat that because most of you are saying, oh, no, they don't want me present. Quite the contrary. Quite the contrary. You'll hear from the moaners and groaners. But people do not want to struggle alone. They want to share that journey with somebody who has more experience, who might be able to help them coordinate things better. So we really need to know how well our guidance system, our leadership system is working. Without standards, however, we don't know what to achieve. We don't know where we're going. So are we serious about our standards? I always say to every CFO, you should be chief steward, not chief financial officer, because without the resources and the money, we're going nowhere. You remember the old saying, no mission, no money, no money, no mission. Well, clearly that is the case today. And if we don't know what's driving some patient safety, clinical outcomes, if the housekeeper doesn't understand the impact cleaning the railings on the bed has for the spreading of C. diff, my gosh, how can we possibly speak to the issue of quality? And maintaining standards consistently. Are they consistently applied? Are we more rigorous? Do we know whether we are? Do we know what we're doing? And without change, we die. So we must look at our readiness for change, our commitment to development, and very critically, our encouragement of people to innovate, to think out of the box, to really do look at everything, from how we wash the floor to how many forms we have, and how much stuff we have. I want to say this to all programmers and IT folks. Please stop over-programming, over-complicating stuff. It's a huge national problem. As we go to move towards our integrated digital records, we are also in the process starting to cripple our systems by programming. There's a priority of information you need. We've got to make sure we're asking for that information and not cluttering it up the whole work. And you want to look at screwing up the work of clinicians. I was on a project recently. When you see how the technology is coming in, it is so powerful. And you can't negotiate with a computer software program. When it asks for information, it won't turn off or go forward until you fill it in. You'll find physicians spending more and more of their time becoming data entry clerks, and the same with nurses. So we got a big problem there. We need innovation in how we enter and process data, among other things. Right. When developed fully in the form of the specific behavioral and criterion competency-based kinds of issues, gives us the teeth we need to take a bite into our environment and understand what's happening.
Well, Emmett, there's a question that's come up.
Yeah.
How do you use technology? If technology is such overwhelming and there are a lot of questions and so on and people are becoming data entry clerks, how do you implement an assessment?
Good question. You use technology.
Okay.
I know you're about ready to lynch me for that.
That's okay.
Actually, the reason we have to talk about it is because technology drives. Today drives change, transforms our lives, and it is the solution for us and the bane of our existence. The issue comes down to committee and priority. Whenever we are programming, we really have to know whether we are reflecting the priorities of our client. And often we think, when we're doing this kind of programming in healthcare, we think our client may be the management, or it could be the financial management, or the insurance company. Clearly, in this situation, I was involved recently, you know of it, Niles, where we had 4,000 partner docs in a very large situation. We found that the primary care physicians, as well as specialists, but particularly primaries, were, by the need to fill out and complete forms and everything, seeing less than 50% of the patient load that they had been seeing prior to the implementation of the new forms. Less than 50%. One of the physicians who came to a meeting, she was in it because of carpal tunnel problems. And she had literally now become, she was being paid at the 75th, 80th percentile, and her productivity was at the 24th percentile. So what we had done was lost sight of who the client was. And when we said the client is the patient requires the physician and nurse. Don't burden them with more just to burden them because somebody needs all this information. We need to start asking what we're asking, who we're asking it of, and how the system should be designed. And so it led to a complete redesign predicated on patient focus and getting those who need to see that patient more available to see them. So that would be an example of what I mean, is that we must make sure we're using technology for good, not do anything. Now, how do we do assessment? Question. Online is a great way to do it, or setting up a little Carol operation in a room in a hospital where people can actually check in, register, and you've known they've completed the assessment. We speak of patient-focused and first operational assessments as requirements of employment. You're collecting information. We're paying you not only to deliver service, not only for that, but you are a part of our sentient living system, and we need your knowledge. So stop in, sign in, sit down, and complete the assessment online or right here on our internal network. So we use technology now as wherever possible.
Well, then how often, Emmett, do you do an assessment?
Yeah, the assessments now are done 12 to 14 months is good. However, once you have the template, it can be used in departments and teams, and there's room for customization so that you can really see specifically into specific team or individual role responsibilities. But on the organization-wide level, whether you have 1,000 or we've done this up to 50,000 people, you really need to look at this 14 to 18 months, every 14, 18 months once you start it. And of course, it can be broken down and sliced and diced just like a CAT scan can. It's a really organizational tomography.
Okay, very good. Well,
questions for?
Yeah, what's the typical cost for doing an assessment, Emmett?
This is probably the most affordable diagnostic in our industry these days. There are initial kind of startup costs, so that typically, regardless of your size, you're going to be involved with $7,500 to $10,000 to get things set up, to make sure the design is appropriate, the questions are there in the appropriate way, to make sure that the results are being delivered, that the feedback script and the understanding that would be most useful, the insights most useful, are drawn out of the data, and it includes some consultation on site. So I usually say if you have 1,000 people in an organization, you're probably going to spend $35,000 to $50,000. And one of the things we do, that may be another question coming right along, if somebody's talking about money, is we guarantee you'll find at least once, but usually more 8 to 20 times, the opportunities for change and improvement over the cost of the endeavor. What's become very clear today is that this form of engagement in the front line produces the insights to save a ton of money and improve the ability, reduce length of stay dramatically, by the way. One of the, I won't say unintended consequences, but one of the desirable consequences of this has been to actually see tighter coordination result leading to lower lengths of stay or maintaining the benchmark or achieving it. But significant financial results do occur. We guarantee the results. Most importantly, people really key at patient safety. Another one, Miles?
Yes, actually, what assurance do I have that this program works? And if I could suggest, Emmett, maybe there's a case study or two that you might be able to cite.
Sure. Let's take one of a a regional healthcare organization that over the past 10 years has emerged from just being a regional to one of the top 100s on a consistent basis. Top 25, American Community Hospital, but it is a very much into tertiary work, so it is also evaluated on that level and beats the cardiac benchmarks, for example, of both surgery and other care. And here, the thing that brought things together was the use of this instrument to focus the organization on a shared agenda of thinking. The problem, a good exercise for everybody to do is get 8 or 10 people in the room, one of you to assume the role of CEO and tell everybody how to draw a specific picture. Then look for variation. Ask people to compare with their neighbors and so forth, and you'll find within those 8 to 10 people as much as 8 to 10% variation in the size, the shape of the picture, and so forth. You go to another one, you get another 8 to 10. You go to a third, you get 5 to 7, and so forth. But you end up with something around 35–40% variation, very measurable. And then you show the picture you're working from, and you get another 20–25% variation. And we often say, who would have surgery if the doctor didn't know clear picture, a 65% picture what to do? That's just about how it works in healthcare. The typical CEO is working in an environment where most people don't know what the hell he's talking about and don't have a real clear understanding of the vision. And now I've been there, and so I've been on the receiving end of that kind of confusion, and I tell you, it's maddening. And how do you get your message out? Well, this is how you do it. I didn't realize when I was first in the business that what you ask is what you stand for. And whoever asks the questions is leading. And the reason is you're getting the information. So the very first thing you do to share with people your vision is put down a list of questions that say what you stand for. We did that in this environment, and my God, it started to bring that organization together. 3,000, 4,000, now it's up to 5,000 or 6,000 people. And among other things that had to happen was tremendous structure design, redesign of work, and that led to a whole redesign effort. And we used this technique every 12 to 14 months to keep us going, to keep us focused. And it worked, and just over those 10 years, this organization blossomed. Another case was after a strike in a difficult setting in the West Virginia hills. I'll just say that. I love West Virginia, so beautiful. But if you want to talk about tough, don't go to New York or L.A. or Miami. Go to West Virginia. There, for example, striking workers wanted to make sure the CEO understood what life was about, so shot some bullet holes, into the driver's side and left a note saying, next time this could be higher. So, where we stand with you. This guy had only just taken the job. He hadn't been there 3 months. But anyhow, what we did was use this assessment to put on the table what was really going on. And we found the UL curve, so over the negative side of the curve, imagine there's 14% of last standard deviation instead of 2. People were really ticked, really angry, felt like they'd been mauled. Over the other side, however, plus side, there were 70+% of all the people saying, we can do this, we must focus, we must put our attention on patient, we must do this and that. The CEO, with tremendous courage, stood in front of everyone through town hall meetings and said, friends, if you're in the 14%, I need to say to you, as much as I sympathize with you, I can't help you. As a matter of fact, as my participation in the thing, I said, maybe you should go outside, take a day off, and come back in as a behavioral patient. But his comment was most telling when he said, we have 70% of you who want to get on with work. And here's our list of priorities that came out of this assessment. They won the American Hospital Association Term Organization of the Year award, and they have been successful ever since. A tremendous success. I cite that when we talk about an organization's hopeless. Nobody will pay attention. Not true. Not true at all. You must ask them for their attention. So these are 2 out of what be well over 1,000 organizations that have participated in one way or another over the years in these assessments and have given us the data to know what to do and how to ask the questions. Another one, Niles, or shall I just quickly move on?
No, actually, we do have another one, and that is, do you provide references?
Oh, as you all know in healthcare, you have to have evidence at every level. Yes, we do. And what we do is the way we handle it is when we have a conversation with you, we match you up with clients we've had the good fortune of working with, and you can talk with them directly. And that's always very instructive for all of us. Very, very critical. I just want to show one thing here before we, there's much more in this presentation, and as Niles said, we're going to share it with you. Niles, you're going to be sending this, right, to people who have attended?
Yes, we'll be able to do that.
Yeah. And one of the things that, as Niles and I have worked on this most recent design and the results from the study, this has proved fascinating because we found very concrete ways to describe what an organization must do behaviorally. I mean, it is so important that we can translate the information into understandable terms. So when we talk about expectations in that quadrant, where we have a whole series of items with it, when it comes down to you get focus. You get optimism and understanding. When you don't have focus, you get contempt, distrust, and misunderstanding. Without ownership, accountability is external. People, in a culture today, we have a culture of people saying, I'm not the one, don't look at me, I'm not accountable. Because we're not encouraging personal responsibility. I think we'll see a return of this, a reinvigoration of that. That's the essence of democracy, surely. And when people own, they are empowered and they're empathic, and they won't own if they're not empowered. And if you don't really let them know, you understand what they're going through. You may not agree, but you understand. And without that understanding, uncertainty happens, and that leads all the way to overt hostility. Without mastery, we can't get any place. So achievement is a function of mastering ourselves. I keep coming back to the housekeepers, who I find to be tremendously receptive when we say, look, those bed rails have got to be scrubbed. And we can't afford bed games, bed availability games in nursing. When we call up and say, is a bed available, we need to know, and we need to know there's enough time to really get the turnaround really well done. The same with the OR rules. So nosocomial infection rates are directly related to really being scrupulous about the cleaning. So mastery of the most minute and what we often think least important thing has to be made clear. And we must be open, even if it's painful, to change. Every time I get evaluations regarding my presentations, I'm impressed by the need for that. When you put these together, though, here's what happens. You get a meta behavior courage. You get an organization willing to step and do things beyond the call of duty because it ennobles the human spirit. Courage results. And when we looked at these results, we realized they're very much like, almost identical. It's just tiny little emphases different than special forces people. And physicians and nurses in the ER and the OR and well, frankly, every unit in today's hospitals is a critical care unit. What we see is courage all the time. What we don't always do is encourage it through the appropriate focus of our questions and of our behavior. Every CEO can lead and develop courage by starting by asking the right questions and doing a patient-centered operational assessment of the type we're talking about. I don't have time here, but we do have a sample. You'll get it, so you'll start to see how it all looks. If this looks familiar to you, what we'll call your attention to is knowing the extent to which people are evidence-wise really keyed in. And so one of the very creative things that's been included in this assessment by our designers, who are just wonderfully gifted people, is the notion of knowing where somebody is individually on an item and where the organization is, so they can see where they are themselves, where the organization is, but we can also see whether people believe they are in sync with us. These are tremendously important types of indicators. We must go past the standard, here's a bar chart, take a look at it. We've got to look at things like we've got to do what we call cluster analyses of symptoms. When you multi-sisters, when you start to find coordination, expertise, timeliness, and all these things come together, what do you start to see? You can see creative distance, you can see dissonance, you can see impending conflict, you can see work squeezingness. When people are being squeezed, and when they are, they're not there. They're gone. They may be present in the physical sense, but there's a term called presenteeism, in which they physically are there, but emotionally and mentally gone. You can actually start to see this, and perhaps most profoundly, you can see things like the hypocrisy risk. People believing we're saying one thing and doing another. We think we're talking about Congress today. These are the kinds of things all of us must know so we can manage more effectively. It only comes through diagnosis. Diagnosis is the key to great leadership today. Anyhow, that's where we are. When you get the diagnosis, your plan, make the decisions, decide whether you own it, and increase the ownership because people know what's expected and where they're going and how they got there, and then you take action. And that increases existence, the possibility of existence, moves us up from existence to stability to achievement and courage. Well, there we are. I'm going through this very quickly, as you can see, and but the point of all of this is to build the ownership and then be ready to run toward the roar. I'd leave you by saying this. Whoever asks the questions leads, so get yourself a great assessment. Whoever has the evidence sets the agenda, so if you ask the questions and get the information, you're going to determine what people are going to talk about. Isn't that be nice if you're a CEO or a member of the executive team, that you're actually setting the agenda instead of reacting to it? And when you do that, you're going to establish a basis for shared ownership, and you're going to avoid the great danger of imposing accountability, and instead you're going to develop responsibilities by hearing, diagnosing, owning. Contact us if you'd like to. We'd love to talk with you about this. We learn tremendous amounts from those conversations, no obligations. But I would say to you, we'd be excited about working with you. This is what makes our job fun, and I think this is what really creates value in leadership. When leaders really know, when they can see it coming. Niles, anything else?
No, actually, that's all the questions, Emmett, and pretty much all the time that we have. But I'd like to say that Emmett's summary of this program really does require action at several levels. We'd love to be able to talk with you, as Emmett said. There's a lot of information in this program that we haven't had the opportunity to go over with you at this time, but we can be able to tailor this particular assessment to your particular organization. In order to do that, of course, we would need to interact with you. So please give us a call. We will follow up with you on an email, provide the slide deck, and we'd like to work with you on a time that would be mutually convenient. So the action is really in your court, so to speak, but it's also in ours too, to be able to work with you and tailor a program that would be suitable for your organization. So thank you all for attending this webinar. If at any time in the future you do have a question for Emmett and me, please contact us. Our website, of course, is www.murphyleadership.com. Emmett has provided you that information on the slide, and will provide you contact information on the follow-up email. As a reminder, at the close of the webinar, a window will appear that will open for a survey. We would very much appreciate if you took a moment and completed the survey. Murphy Leadership was very excited to present this program and event to you for today. We look forward to working with you in the future. Thank you, and good day or good evening wherever you may be. The webinar is now concluded. Thank you again for attending.